Hello, I'm Guillermo Umpierrez, a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. Welcome to this educational activity on managing glycemia and weight in people with type 2 diabetes. Thank you to Peer Review for providing this session and Lily for providing the educational grant for this symposium. We have prepared practice aids that are designed to be helpful to your practice. So please download these resources by clicking on the practice aid icon. Finally, submit your question throughout this program using the live chat feature. I will address them in the Q&A session. Our goal for today is to equip you and provide you with the evidence or recent evidence to view weight loss as the treatment target in people with type 2 diabetes. First, we're going to review the guidelines. The American Diabetes Association has recommended during the past 5 years a holistic person-centered approach for managing patients with type 2 diabetes. The overall goal is to improve glycemic control to prevent long-term complications and optimize quality of life of people with diabetes. And to do so, first, we need to achieve glycemic management, glycemic control. Intensify, break inertia, and you can have one or multiple medications. Right now, we have 12 different types of medicine with different mechanisms of action for treatment of diabetes. And we want to improve glycemic control, but at the same time, prevent hypoglycemia. Second, we want to achieve weight loss or weight control. To do so, we need to first set up goals, targets. Second, educate our patients about lifestyle intervention, diet, exercise, and consider medication when there's needed. Third, we want to improve cardiovascular risk factors, blood pressure control, lipid control, antithrombotic agents, and of course, smoking cessation. And finally, during the last few years, we learned about these two group of medicine, the GLP-1 receptor agonists and the SGLT2s, that have been shown to have cardiovascular and renal protection. So this is the holistic approach. Let's concentrate to the figures in the right. To reduce hemoglobin A1C or improve glycemic control, as I mentioned, we have multiple medications which usually start with metformin or combination therapy. But now we know that if the patient already have complications, we should go and treat patients with GLP-1 or GIP, GLP-1 or SGLT2s. When you look at efficacy, the dulaglutide and semaglutide has much better glycemic control than other medications like SGLT2, sulfonylureas, or TCDs. When we look and think about weight loss or reduced weight, the only medication that have really been successful are the GLP-1 receptor agonists and the dual GIP-GLP-1, who has greater efficacy in weight loss. This slide shows the glucose lower agency effect on hemoglobin A1C or glycemic control to the left. And you see that the dual agonist GIP-GLP-1 together with GLP-1 receptor agonist has much better glucose control, even better than insulin. In the middle is the effects on weight loss, or body weight in kilograms, with the GLP-1 and the GIP-GLP-1 has much greater effects. And of course, we learned throughout the years that insulin is associated with increased weight. And to the right, we have hypoglycemia, where only sulfonylureas and insulins are those who are associated with hypoglycemia, where the GLP and GIP-GLP-1 or dual agonist has much better glucose control, weight control, with no evidence of hypoglycemia. So there is a good correlation between the effects on weight and hemoglobin A1C. For those agents, a GLP-1 or dual agonists, who we see that have much greater effects both in hemoglobin A1C reduction, you can achieve 1.5 to even 2.5% with semaglutide and tirzepatide. While other initial GLP-1 like exenatide, Lixi, has very little weight loss, lower reduction of hemoglobin A1C. This is an important message. The more weight loss, the better in the reduction of hemoglobin A1C. But it's not just hemoglobin A1C. When we combine GLP and dual agonists with diet and exercise, is indicated for all patients with type 2 diabetes. That we also had learned that you can reduce MACE, major adverse cardiovascular events, that include acute myocardial infarction, strokes, and cardiovascular death. And studies with dulaglutide, liraglutide, and semaglutide have shown reduction in MACE. Studies with tirzepatide are ongoing. So not only that you're going to achieve glycemic control, not only that you reduce weight, you can also have an effect on outcome and mortality. So how much weight? This is a question that is usually asked. How much weight do I need to lose to improve glycemic control? And just 3 to 5% has significant impact in reducing hemoglobin A1C. Even prevent diabetes. Is 3% also reduce triglycerides. You need a little more weight loss to have an impact on blood pressure, metabolic associated hepatic liver disease, 5%, and to improve quality of life, you need to lose 5%. When you talk and see a patient who has NASH or non-alcoholic steatohepatitis or apnea, they're related to obesity, you need 10% of weight loss. And if you ever have a patient that loses 10 to 15% of body weight, you're not only going to improve glycemic control, all of these comorbidities that we mentioned, but you're going to have effects on cardiovascular mortality and also remission of type 2 diabetes that we're going to talk in a few minutes. The greater weight loss is associated with greater improvement of cardiovascular risk factors as shown in these slides. This is weight loss at 5%, 5 to 10%, or in the green line is more than 15%. And here you have more weight loss is associated with significant reduction. And this is starting with the hemoglobin A1C of 8.5%, you have less than 7%. The same thing for weight, and look at the effects on blood pressure. With significant weight loss of 10 to 15% or more than 15%, you have normalization of blood pressure in the majority of patients with type 2 diabetes. And to the right is the effects on triglyceride. You improve insulin sensitivity and the activity of the lipoprotein lipase, and you have You can hydrolyze triglycerides and have these effects coming from 200 to less than 140. When we review the results of the clinical randomized studies with the use of tirzepatide like SURMOUNT and SURPASS, you have the effects on MACE and cardiometabolic outcomes. The pooled tirzepatide doses of 10 and 15 milligrams resulted in reduction of blood pressure about 7 millimeters of mercury, triglyceride reduction about 30%, increase in HDL, and a reduction in non-HDL cholesterol. And that cardiovascular risk factor resulted in a trend on a reduction in MACE, major adverse cardiovascular events, myocardial infarction, strokes, and hospitalization for angina. So the same thing, this is with semaglutide. Higher semaglutide doses, the 1 milligram, 2 milligrams, have a much better effects on hemoglobin A1C. Here you have to the left is the percentage of patients that achieve a hemoglobin A1C less than 7 is close to 80%. Blood pressure reduction and achieving of blood pressure less than 140, 80%, non-HDL cholesterol, and metabolic composite. Semaglutide has been shown to reduce MACE by 26% in the SUSTAIN 6 study and 21% in the PIONEER 6. This is a reduction of mortality, acute myocardial infarction, and stroke. In addition, semaglutide was recently reported in the New England Journal of Medicine that in patients who has heart failure, preserved ejection fraction, semaglutide resulted in improvement, what is called the Kansas City questionnaire. That's quality of life of people with heart failure. And as you see in the graph to the left, significant improvement as you see this after just a few weeks of therapy. And to the right, semaglutide led to larger reduction of the primary outcome that was improvement of quality of life, improvement of significant symptoms of heart failure, and no hypoglycemia. The FLOW trial was recently published in the New England Journal of Medicine, and it's the first trial, the first randomized controlled trials that investigated on the effect of GLP-1 receptor agonists as a primary kidney endpoint. In this study, 3,500 patients with type 2 diabetes and chronic kidney disease were included. These patients have a GFR between 25 to 75%, and they have significant albuminuria. And they were treated with semaglutide or placebo. The primary outcome was a composite of cardiovascular and kidney morbidity and mortality. And what they reported is the first major kidney disease event that included a reduction of GFR to less than 15% or the need for dialysis. And that was reduced by 24%. They also reduced MACE, major adverse cardiovascular event, by 18%, and showing the graph to the right, death from cardiovascular causes was decreased by 20 to 30%. And of course, there was significant weight loss, even in these patients who have high risk because they already have chronic kidney disease. Not only for 24 weeks or 48 weeks, here you have, there are 2 or 3 studies have looked at the effect of long-term utilization of GLP-1. In this case, semaglutide, up to 500 days. There are other studies that are even longer duration. And what you have is that the higher the hemoglobin A1C, you come down to less than 1% reduction, 2% or 2.5%, and the effect is sustained. And to the right is the effects on weight loss. When you took this medicine, it's going to be working and people is able to achieve weight loss and maintain weight loss all the way up to several years. When you compare the effects of tirzepatide versus semaglutide, it was recently reported in these observational studies a benefit of tirzepatide over semaglutide. This data shows at 3 months, 6 months, and 12 months. And pay attention here to the right. The effect of tirzepatide on weight loss was greater than the effect of semaglutide in these observational studies. Let's talk about combination therapy or other agents like SGLT2, GLP-1, and dual agonists, GIP, GLP-1 receptor agonists on weight. So the first thing when we see a patient that is interested in weight loss or you want to help patients to lose weight, the first thing is to set achievable, realistic goals. So improved glycemic control is 3%, but we already said that 10-15% decreased cardiovascular outcome, improved cardiovascular outcome. So we're going to set up your management plan. We're going to discuss about the GIP, GLP-1 therapy, because we know that these are effective as we have discussed. When you talk and you combine, when you think about agents that are being associated with weight loss, you have SGLT2s, a minor reduction in weight loss, but combined with GLP-1 has been shown to improve outcome. You can reduce all-cause mortality and MACE, both with GLP-1 and SGLT2s. GLP-1 have been shown to reduce the risk of stroke. And there is no question that now all of our friends cardiologists are using SGLT2s in patients with heart failure. But it's not only that reduced heart failure hospitalization, it also has cardiovascular and renal protection. In the FLOW study, we saw the effects of GLP-1 on kidneys. Now SGLT2 has been shown to decrease albuminuria and decrease progression of chronic kidney disease. More recently, we learned about tirzepatide, a dual agonist, a GIP-GLP-1, that has good effects on glucose, triglycerides, blood pressure, and all the cardiovascular risk factors. So in meta-analysis, we have seen that the use of SGLT2s and GLP-1 alone and in combination have been shown to be quite effective. What about insulin? The American Diabetes Association during the past 5 to 7 years have recommended that if when the time comes for use an injectable, GLP-1 should be preferred over insulin as the first line agent. Why? Because it has similar effects on hemoglobin A1C, but it's associated with weight loss, no risk of hypoglycemia. Unfortunately, these are complications or side effects that we see with insulin therapy. But the combination, when glycemic control is not achieved, or when the patient has cardiovascular risk factor, the combination of insulin and GLP-1 should be considered. They have complementary approach to reduce hemoglobin A1C, increase insulin, decrease glucose, increase glucose uptake in peripheral tissues, and decrease hepatic glucose production with the combination of basal insulin. In addition, you have decreased appetite, slowing gastric emptying that improve postprandial glucose control. In this presentation that was just recently published in Postgraduate Medicine, applies the 3 E's, and I think this is extremely important to keep in mind when we consider the treatment with GLP-1 or the dual agonist GIP, GLP-1. So the 3 E's includes education and explanation. You have to tell the patient about what is anticipated. The gastrointestinal adverse event, that's where we start a low dose. That's the escalation. You start a low dose, and every month you're going to increase the dose as tolerated when the gastrointestinal adverse event goes away. And the third E is effective management of GI adverse events. We have to tell the patient to be hydrated, increase fibers, decrease fat intake or the fatty meals, and eat slowly, and the patients are going to have decreased gastrointestinal adverse events. So let me move now to weight loss as a tool for diabetes remission. So this slide, I think we all diabetologists have seen this slide because it's like 20 years old. And what it shows is the type 2 diabetes progression in relation to beta cell function. For at the time of diagnosis of diabetes, we believe and studies have shown that there's significant beta cell function, maybe 40-50% is already lost. So Before, for diabetes prevention, it's easy when you have good beta cell function. Diabetes remission can be achieved during the first 5 to 10 years, within the first 10 years of the initial diagnosis of diabetes, because you still have beta cell function. Now, it is very hard to know when diabetes type 2 starts, but if the diagnosis is made and you have somebody has 5, 10 years, you can achieve diabetes remission in a significant number of patients with type 2 diabetes with weight loss on medications. So what is diabetes remission? The Endocrine Society and the European Association of Study of Diabetes and the UK Diabetes recently had a consensus definition. It is sustained metabolic improvement in type 2 to near normal levels of hemoglobin A1C, so hemoglobin A1C less than 6.5%, that is achieved with no diabetes medicine for at least 3 months. So this is a good definition because we know that we can achieve glycemic control and normalization of hemoglobin A1C. There is significant reduction on the risk of complications. In the pool analysis of 4 US single centers randomized control studies that investigated the long-term effects of weight loss, and here you see a comparison between bariatric surgery and medications. These studies were done before the availability of GLP-1 and the dual GLP-GLP-1. And of course, bariatric surgery is much more effective than old medicines. You can achieve 50 to 60% reduction or remission of diabetes with surgery. 2 years and 5 years later, unfortunately, only 30% to 40% of patients with bariatric surgery is still in remission. And medications, can you achieve remission? Yes, if you lose weight. But it's not only medication. There are studies like the DIRECT trial in the United Kingdom that have shown that significant weight loss with diet of 800 to 850 calories, when they lose 5 to 10 kilograms, up to 15 kilograms, you see a remission in somewhere around 50 to 60%. And if somebody loses 15 kilos or more, in patient who has short duration of diabetes, less than 10 years, about 80% can achieve diabetes remission. At year 2, there is some decrease in remissions, but you can achieve, if somebody still lose more than 10 kilograms, 60 to 70% of patients with just diet intervention they achieve remission. So hemoglobin A1C less than 6.5, no medication for diabetes. The DIRECT trial recently published the 5-year data. And even after 5 years, those who continue to lose weight or maintain the weight loss achieve remission is somewhere around 25%. So lifestyle intervention is important to achieve remission. The same thing was published many years ago, and this was the Look Ahead trial, an NIH trial that have intensive intervention in patients with type 2 diabetes. And unfortunately, it's not as successful in weight loss as we see with the DIRECT trial, but somewhere around 10 to 12% of patients achieve remission. And this is remission after 3 and 4 years, this decrease, very low, because it's very hard to maintain body weight. And here you have the effects on hemoglobin A1C, and to the right, the change in body weight in the Look Ahead trial. The primary outcome of the Look Ahead trial was decreased cardiovascular complications. That was not observed. When you see the hemoglobin A1C, unfortunately, has a very nice reduction in the first year, but progressively increases the hemoglobin A1C up to the year 10. And the same thing happened with weight. Lifetime intervention resulted in significant reduction of body weight, somewhere around 8 to 10 kilograms. But unfortunately, with increased duration of intervention, they observe an increase in body weight. So lifetime modification is the foundation of weight management. We should always start with lifestyle. But we have now medications because we know that achieving and maintaining weight loss is difficult with just lifestyle. There are agents like oral semaglutide or SGLT2s. And here you have the effects of DAPA with weight. To the left is hemoglobin A1C. And here you have the combination of DAPA and semaglutide. And you see that it's a nice effects on hemoglobin A1C and reduction. But DAPA by itself, SGLT2 is associated with 2 or 3 kilograms max of weight loss. But now we have medicines who are extremely effective in weight control, like tirzepatide, the dual agonist, GIP, GLP-1. And when you look at here is those, if you treat patients with type 2 diabetes, to the left, the percentage of people who has achieved a hemoglobin A1C less than 7% with no weight gain and no hypoglycemia. And you have 80 to 90% of them achieve control. In that studies were compared with insulin. And unfortunately, insulin is not very good in achieving glucose control and maintaining glucose control, and of course, it's associated with weight gain. So when you look at the right, is achieving hemoglobin A1C target less than 7%. The use of tirzepatide resulted in 80 to 90% effective in reducing hemoglobin A1C. So when you look at all of these trials, randomized control trial with tirzepatide, you can achieve normal glycemia and hemoglobin A1C less than 5.7%. And you see here that compared to placebo, when you look at here versus all of the different trials on different medications, tirzepatide was effective in improving glycemic control and increased the odds of maintaining normal glycemia, hemoglobin A1C less than 5.7%, 16 times better than other agents. Some practical recommendations that you can use when you're in your clinic. First, we have seen this slide for the last few years have been little modifications, but this is a recommendation of the American Diabetes Association standard of care for the management of patients with type 2 diabetes. To the left, you have a cardiovascular risk reduction. Now we also have heart failure reduction and reduction of kidney complications. So in patient who has multiple risk factor or established cardiovascular disease, the recommendation is to start on a GLP-1 and SGLT2. If it's necessary for glucose reduction, you can add metformin or other agents. For heart failure, we know that SGLT2 reduce the admissions to the hospital and reduce mortality by 20 to 25% in patients with heart failure. Now, we also show that GLP-1 may also help in patients with heart failure. For chronic kidney disease, those patients who have decreased GFR less than 60 or the presence of albuminuria, the first line agents and recommendation is the use of SGLT2s. But I also just show you the flow studies that the GLP-1 has a beneficial effects in cardiovascular mortality in patients with chronic kidney disease. The second part of this recommendation of the American Diabetes Association is weight maintenance. So this is extremely important because obesity is the reason why we have so much diabetes. And we should avoid medication associated with weight gain and use medicine and educate patients and start lifestyle intervention with or without medication for weight loss. An agent that associated with significant weight loss are the GLP-1 receptor agonists and the dual agonist GIP-GLP-1. This table shows the different GLP-1 receptor agonists and the dual agonists on the doses that are available, medications that are right now on the market, and you see that you can go and the most important thing is to start at low dose and start increasing the dose, usually every 2 to 4 weeks as tolerated. The gradual increase of doses reduces significantly gastrointestinal adverse events and acceptability of the patient to continue to take this medicine. Because we know that if you stop these medications, there's weight regain. And finally, how do you talk to your patient? So first, save time and dedicate the time to talk to your patients about what is expected, what are the goals, tell them about potential adverse events, the GI adverse events, the importance of start slow and dose escalation. So you have to wait for 2 to 4 weeks. You also have to tell the patient that try to avoid these large fatty meals because that may be associated with increased gastrointestinal adverse events. And the maintenance phase is extremely important, right? See the patients or send the patient to the dietitian, to the nutritionist to help about food selections that may be associated with greater weight loss. If the patient has gastrointestinal adverse event, well, you can use antiemetic or prokinetics. If you have, or decrease the dose, if you have constipation, use stool softener, consider reducing GLP-1 dose. So these slides are available to you. So the key message to take away, there are now medications that regulate glycemia. We have 12 different groups of medicine that help us to glucose control. But now we have medications that are highly selective that also produce weight loss. The GLP-1 receptor agonist and the GIP-GLP-1 receptor, the dual agonist, not only improve glycemic control, not only decrease weight, that have been shown to improve cardiovascular outcome, the MACE, major adverse cardiovascular events, decrease mortality, improve kidney function. So the goal and the future of diabetes control is weight control. Use selective agents have been shown to have cardiovascular and renal protections and decrease cardiovascular mortality. I thank you so much for your attention. This concludes my presentation for today. Now it's your turn. Please stay in line and we will answer as many of your questions and challenging cases as much as possible. Thank you so much.
Good evening, everyone, and welcome to this portion of this evening's program. I'm Dr. James Gavin. I'm an endocrinologist. I work as a Chief Medical Officer for Healing Our Village, and I'm also a clinical professor at Emory University. And we are going to try to answer as many of your questions as we can get to in the next 30 minutes or so. And in fact, there is a question already that's come in. It says, I saw a patient today with diabetes and an A1C of 7.1, a BMI of 32, with comorbidities of hypertension, fatty liver, urine microalbuminuria. Is it better to start a GLP-1 or an SGLT2 inhibitor? Well, here's a case where you do have options, and what drives your choice in a case like that really has to do with what are your goals. And this should be what are your goals in alignment with shared decision-making with that patient. Clearly, the patient is close to, but not at goal with A1C. So you certainly can benefit from some additional A1C reduction. But the guideline-directed therapy that we now are encouraged to follow with patients who are at risk for ASCVD or who have known ASCVD. And here's a person who clearly has microalbuminuria, and I'm assuming that already has CKD. So you already have some direction. For example, if this person has CKD already, then we would lean in the direction of an SGLT2 inhibitor. Okay, if this patient has known underlying atherosclerotic cardiovascular disease at a BMI of 32, you certainly could add some fatty liver, you certainly would be well advised to think about adding a GLP-1 to this patient's regimen. But don't stop there, because remember that you have also the notion of what's going to be available and affordable for that patient. Either of these two choices could do a lot of good for this patient, but you want to put this patient on a therapy that's not only going to be effective, but sustainable for that patient. So now you got to think in terms of some of that patient's social determinants of health as well. The second question here is, if my patient is taking a GLP-1 and has reached their A1C goal, but would like to continue to lose weight, should the dose be increased to match the dose of comparable GLP-1s marketed for weight loss? So this is an interesting question, because what it implies here is that you might be in a titration phase with this GLP-1 that the patient is on right now, but during the titration phase, before you've reached the maximum recommended dose of that GLP-1, you've already gotten to an A1C goal, but now your goal is apparently no longer just A1C. You want to continue to see some weight reduction. With that same GLP-1, remember, you're not going to drive that patient into hypoglycemia by using that GLP-1 that's been effective in lowering their A1C. If you still got room in the titration for that particular drug before you max out the recommended dose, keep using that GLP-1. There's absolutely nothing which prevents you from doing that and getting weight loss. Now, but if you're asking, should you use, say, that same drug, which might have been approved for weight loss at a higher dose? Remember, you're crossing a line. Okay, you've gotten approval to use this drug in that patient for their diabetes, but now you're pushing the envelope to now make it a weight loss regimen. That's a little bit of a sticky wicket, and you may want to think about the fact that may not be your best move. Max it out, get as much weight reduction as you can. But now, if you want to get the agent for a different indication, that may be now time to revisit how you talk with that patient and how you now approach the use of the GLP-1. Here's a question. I have a patient with diabetes that's maxed on orals and a weekly GLP-1 and still not at their glucose goal. What should I do next? Well, this is a question that's straight out of the guidelines for the algorithms for medical management of diabetes. Remember that if you have a patient that's already maxed on orals, not at goal, and has already begun their first injectable therapy, in which case you're using the first injectable that's recommended by the guidelines, which is a GLP-1, your next step for that patient is the addition of basal insulin. Or if you're a person who likes the fixed ratio combination drugs, where you have in one injection the combination of a basal insulin and a GLP-1, that's an alternative for this kind of patient. There are clinical trials that have been done for precisely this kind of patient, maxed on orals, using a GLP-1, or using just a basal insulin, where the combined agent GLP-1 plus basal insulin has been extremely effective. So this is the case of a patient that's now in need of additional injectable therapy in the form of basal insulin, according to the guidelines. If a patient did not get their A1C to their A1C goal on maximal dose semaglutide, 2 milligrams per week, should I increase the dose range increase it up to the dose range that's been approved for obesity? the patient only is only overweight, not yet reached the benchmark for official obesity. Well, this gets back to the earlier discussion we were just having. If you've maxed out with this agent as a GLP-1 receptor agonist and you didn't get to goal, it may very well be that you're not going to get to goal for this patient using the GLP approach. Okay, pushing the dose of this drug may not be, in fact, what will get you there. You may need to either use a more potent GLP-1, or you may need intensification of therapy. Okay, that's what would be the approach recommended by the guidelines. Not to now try to use the quote obesity approved dose for a glycemic target. That's not what has been approved. Okay, and that would not generally be the recommended course of action, especially if you don't have a patient who would qualify for GLP-1 for obesity, because you're saying the patient is not obese. So here you got a question of a patient who needs intensification of their anti-diabetes therapy, not pushing an agent that clearly has not been able to achieve the target goal on the maximal recommended doses. Okay, intensify or change to a more potent agent. The question here is, I recently saw a patient with type 2 diabetes and an A1C up to 10.2. A long discussion of medical options, and chose to start insulin with CGM due to the cost of the GLP-1 and failure/side effects on metformin and the GLP-1. Do you think I should revisit the GLP-1 conversation? Well, you certainly could do that, okay? But if the side effect profile was sufficiently severe, you may not have a patient who's entirely friendly to that discussion. But if you were in the titration and you got to a point where you were on higher doses of the GLP-1 that you initially chose, and that's when you ran into problems, you may want to revisit the GLP-1 story, but only if you have access to a different GLP-1 that might be more potent in, for example, in getting patient to goal. But you have other options here. If what you're really trying to do in a patient who has an A1C of 10, you have other options that you could resort to. For example, it is not clear that this is a patient, for example, that if they couldn't or get access to or couldn't tolerate the GLP-1, is this a patient that could use an SGLT2, for example, as a combination with their metformin or with even with the GLP-1. So there are options that you can explore. Certainly you could revisit the GLP-1 conversation, but you have to do it with some view of what was the problem that caused it not to work so well the first time, and would you be essentially following a pathway that's a little different in terms of what the expected outcome, either because you chose a different agent or because you decided on a different approach. You're going to use a different titration schedule or something that would mitigate the risk of having the untoward GI effects. Okay, what is the approach to hyperglycemia that's resistant to treatment with an A1C less than 9? What general diet recommendations in regards to protein, carbohydrate, in terms of grams for each meal? Well, I think you have to parse this question now. If you're talking about a patient who's not getting to goal, the A1C is not being able to get to goal because you maxed out the available therapies. Be sure that that criterion has been satisfied, that you maxed out the available therapies. Again, I point you to the guidelines as they currently exist. Remember, once the diagnosis is made, your decision for a treatment path is really not initially based solely on A1C. It's based on what are the underlying risks, particularly cardiovascular risk, because that allows, or CKD, because that allows you to select whether or not you need a GLP-1 and or an SGLT2. First pass, okay? If in a patient that's at risk or has underlying cardiovascular or kidney disease, okay? If the patient doesn't fall into that category, now you've got a whole host of other options, including all of the available agents, including the SGLT2 inhibitors and the GLP-1s, which now can be used for the sake of lowering the A1C. If those drugs have been used and used according to the recommended guidelines, and the patient's A1C cannot get below 9, the guidelines tell you clearly that this is a patient that's going to need insulin. Okay, so just make sure that you've gone through the appropriate steps in the guideline-directed therapy that we are supposed to be abiding by now before you reach a judgment about what pathway is available for that particular patient. Now, when it comes to lifestyle recommendations, especially medical nutrition therapy, I'm going to give you a recommendation, and that is to go to the ADA standards of care in diabetes care of January every year. That's when they are published in January of every year. And in the chapter on medical nutrition therapy, and the reason that I do that is because there's a whole slew of recommendations about medical nutrition therapy where the basic gist is there's no one size that fits all when it comes to recommendations about what the dietary plan or the medical nutrition therapy plan should look like. Okay, that there's some people that have found that the plate method actually works extremely well. But if you want a prescription of whether or not for this patient you need 50% carbohydrates in their for their meal, 20% protein and 30% fat, and then if you do a total calculation of how many calories a day does that person need to have, now you'll divide it up into how many grams of carbohydrate, how many grams of fat, how many grams of protein. Those are the steps that you would be having to take. There is no one size that fits all. There's no one program that will be recommended as the program of choice. Many people have found, based on the patient's clinical profile, diets like the Mediterranean diet, like the DASH diet, those are very good approaches. But what I would suggest is that if you want to get a comprehensive view of what medical nutrition therapy should involve and what the components should look like for the patient that you are interested in, the chapter on medical nutrition therapy in diabetes care, the standards of care for 2024 would be an excellent place to spend a little time, because these recommendations are all over the place, okay? And more than we can cover in the whole session here tonight. Okay, how much weight, that is percent of total body or current body weight, does one have to lose in order to effectively improve health and protect against metabolic illness and inflammatory conditions? Well, I'm going to give you another guideline here that is going to be very useful, and then I'll give you a little bit of reasoning of why I make that recommendation. And that guideline is this: go to, just like I advised you to go to the ADA Standards of Care in Diabetes Care, January edition, the ACE AACE/ACE, Obesity Clinical Practice Guidelines. Please write that down and just Google it, because they give you the most comprehensive summary of what approaches should be used and are recommended for treatment of obesity as a contributor to a whole variety of illnesses. And I'll give you some examples. For example, if you have type 2 diabetes, the best data, and that's why the ACE guidelines are so good, the best data suggests that in order to prevent progression of their diabetes and in order to achieve A1C reduction in patients, when you're using their weight reduction as a tool, you need 5 to 15% weight reduction. If they have prediabetes, then 80% of people with prediabetes achieved a 10% weight reduction, and that prevented them from progressing to type 2 diabetes. For CVD, it's not recommended to use obesity or weight reduction as a means of CVD prevention. It's certainly useful, but it's not recommended as one of the therapeutic interventions that will change CVD outcomes. And you can go to the ACE guidelines to see the evidence for that. For asthma, 7 to 8% reduction of their baseline body weight will give you improvement of their underlying respiratory disease. And if you look at non-alcoholic steatohepatitis, fatty liver disease, now you're talking about up to 40% of people had a decrease in liver inflammation and fatty liver with a 5 to 15% weight reduction. So the recommendations are tailored to what the evidence has shown for the particular disease in question. In general, you're going to see that number go from anywhere from 5% to 15% for meaningful clinical impact. How you achieve that reduction is a different question, because there are multiple pathways that can be used. Which of the GLP-1 receptor agonists has the highest potency? Well, when you look at the way those agents break down with respect to their potency for weight reduction, okay, and right now that's a pretty good index or metric. The highest potency of agent is tirzepatide, followed by semaglutide. I'm only now talking about the approved agents. The next one would be dulaglutide, which is about third in line. Then liraglutide and dulaglutide are pretty comparable to each other. And then you get into the older generation agents. Exenatide and lixisenatide are the ones at the lower rung of the potency ladder. Now, when it comes to lowering of A1C, they actually follow pretty closely that same kind of hierarchy, okay? At what EGFR should we stop the GLP-1? And you'd have to really look at the recommendations for the specific drug that you're using, because for some of them, they are metabolized by the liver. They don't really depend on renal clearance. But for the ones that have some degree of dependence of renal clearance, you need to know that. So that's an individual drug type metric that should be explored. There's a question here: how much weight loss is expected per month? Very nice question, because this refers back to an earlier question that we responded to, namely, do all of these agents act the same? Well, no, they have a pretty wide spectrum in terms of their beneficial effects on the um, uh, metabolic parameters that they influence, like weight loss, for example. What you find is that in the trials that have been done, for example, with semaglutide, the amount of weight that is lost per week differs at the stage of titration. Okay, in the first month, generally what you see is in the first month you see a weight loss in the range of maybe 10 pounds. Okay, by the time you get out to the later stages, now you're seeing in the 4 to 6 month range, you're seeing weight loss up to 15 pounds. Okay, now if you look at a drug like tirzepatide, okay, you may be looking at an initial weight reduction of maybe 7 pounds per month, and then now as you go out further, that monthly weight loss may again get up to like 15 pounds. Okay, and that's again going to be something that's going to differ according to the drug that you use. With the shorter acting agents, you're not going to see much movement like that at all. Okay, the shorter agents just do not give you that degree of weight reduction. But the longer acting agents, particularly semaglutide, tirzepatide, to some extent liraglutide as well, are going to give you that kind of weight loss on a monthly basis. How long should a patient be off oral and injected GLP-1 medications before surgery? Very good, because it all depends on whether or not you're talking about an elective surgery or an unscheduled or an emergent surgery. You would like to, if a person is on a long-acting GLP-1, you'd like to have that person off of that drug for the dosing schedule. If it's a weekly regimen, you'd like for them to be off of that drug for at least a week. Okay, but that's if it's elective, if you have time to plan like that. But suppose somebody comes into an emergency room and they need a non-elective surgical procedure. Well, now you may not have that luxury of stopping the drug. Now you have to do things like make sure that you minimize the chances of aspiration or some complication of that sort. And they have in surgery what they call a full stomach protocol. Where they recognize that they may have to do an ultrasound to see how much, what the contents of the stomach might be at the time of the procedure, and then take appropriate procedural cautions if you cannot, for example, get the patient off of the agent for a period of time that will allow for the gastric contents to be dissipated. Okay, so elective versus non-elective, if you have the option, please keep it off for the recommended period of time. Does GLP-1, what are the best evidence-based approaches to patients with GI side effects, that is constipation, nausea from GLP-1 medications? Well, you know, this is not the kind of thing for which there are, if you will, clinical trials done, but there are clinical experiences that have been well documented that, you know, there's a recent, well, it's not so recent, but a publication that's come out of the Cleveland Clinic where they've looked at the 3 E's to evaluate, experiment, and then you titrate. Okay, basically what you do is look at whether or not the patient's titration schedule is one that needs to be slowed down if you're in the titration phase, because you may need to back off. Okay, if you're having these kinds of GI problems. Okay, you may need to interrogate the patient to see whether or not there are behavioral interventions that you can use. Can you change eating patterns eating nutritional content in a way that can ease some of the GI distress. A strategy of last resort has generally been considered using additional medications. That is, stool softeners or um, anti-motility drugs or agents that would in some ways affect the motility of the gut, because in the first place, you're going to be adding to the complexity of the medical regimen. So it's generally considered that the better approach would be to really do a careful evaluation, looking at behaviors, practices, the titration schedule, and whether or not it's time to back up and slow down on the titration schedule to really mitigate some of these GI distress. And does the GLP-1 associated weight loss lead to decreased colorectal cancer risk? That I really have, I do not know of any associated increased risk, okay, of colorectal cancer with the GLP-1 receptor agonist. I would say that the longest term outcomes that have been reported with these GLP-1s has been with exenatide. Okay, exenatide has been around for since 2005. Okay, and there has been, to my knowledge, no studies which have been, or no meta-analyses that have reported an increased signal of colorectal cancer with these drugs. Even the thyroid medullary cancer risk is one that, again, the data are not impressive, and there's going to be a registry that has been going on for 10 years, come 2025, that will report out. And so far, there's really not been an impressive signal, even for medullary thyroid cancer. And pancreatic cancer, same kind of deal. These are the kinds of risks that we're going to have to learn a whole lot more about by the interrogation of real-world data, and EMRs and AI will help us with that. But right now, there are no studies that I'm aware of that really inform these relationships between GLP-1 use and various cancers, whether GI tract or otherwise. Okay? And in 10 seconds, what do you say when patients ask about stopping the medication when their goals are achieved? That, you know what, they can do that, but virtually everybody will regain the weight. Okay, and the only data to the contrary is if people taper off of their GLP-1, and a tapering off as opposed to stopping suddenly is associated with a much more stable pattern of maintenance of weight loss with the GLP-1s. So I think that was the last question that we have time for. I hope some of your concerns have been addressed, and I thank you very much for your input and for your attention this evening.